few administrative items to go through first, and then we will show the agenda, and I will hand off the call to one of my colleagues, Linda, and we'll kick off. If you have not been on these calls before, we would like to give you a friendly reminder to make sure your device is on mute. If you don't know how to mute your device, you have a little microphone icon in the attendee list next to your name, and you can click on that as well. We do use the chat feature for these meetings. We've had some great chats in the past, and we really appreciate you participating when others have questions and adding your input and comments. So feel free to send your chats to everyone so that everyone can see them and respond to them. And we do track those after the meetings and respond if anyone has any questions that we cannot address during the call. Next slide, please. This is our antitrust practice slide. We are a Gravity Fire Accelerator, HL7 Fire Accelerator project, and this is part of our governance, so we include it at the head of the deck so that you always know where to find it. Next slide, please. If you have not already joined the project as either a committed member or an other interested party, we encourage you to do so. You can find the join page on our Confluence, and we have all levels of participation, and we appreciate all levels of participation. And this will add you to our listserv so that you can receive emails and calendar invitation updates from us. So please do join if you have not already done so. Next slide, please. These are our sponsors. We have many people who are supporting this work, and we ever so appreciate it. We can't do it without you. And like I've said before, this list continues to grow, which we just think is absolutely remarkable, and we are ever so humbled. And please make sure your videos are off and mute yourself. Thank you. If you are interested in sponsoring, if you want to go to the next slide, you can either email us, or there is a big blue button on the landing page of our Confluence that allows you to fill out a little form to express your interest in sponsoring Gravity's work. Next slide, please. We are hiring. Exciting news. We are looking for an individual. We currently have, just so everyone's aware, we currently have 2 project managers for this project. I am one of them. This is Lynette Elliott. And our other project manager is Katya Schell. And we manage different parts of this project. And we are looking for someone who can manage both the terminology work, which is the call that you're on, that's the kind of thing for that, and the Fire IG work. So if you are interested in joining the team as a project manager who can oversee all of this work, we would love to hear from you. You can email us, or there is an announcement on the landing page of our Confluence if you want to go there and read the job description and submit an application. Next slide, please. We have a full agenda, as you can see. We will go through some short announcements and our project roadmap and upcoming schedule. And then Linda Hyde will take you through an update for the food insecurity terminology submission statuses. And she will also update you on housing instability and homelessness data concept submissions. And she will also share how many submissions we've had and who has submitted. And then Sarah will lead you through a discussion of the end-to-end review for housing diagnoses and goals, which we have not covered yet. And then Linda will speak with you about inadequate housing data concepts and the ones that have been submitted to date. And then Sarah will take you through a discussion on inadequate housing, and then we'll cover next steps and homework, as well as a review of the Gravity terminology development process. Next slide, please. And again, if you just joined us on this call, you can always use the chat feature to pose your questions and comments. Just address your comments to everyone, and others will be willing and able to jump in and answer questions or pose comments. This is our schedule. We apologize, there was some confusion on the dates, and we have made sure that those are correct now. Today is the 25th, and then our next meeting will be 2 weeks from now on July 9th, and then we continue the 23rd and August 6th. Next slide, please. This is our roadmap. This is a snapshot of all the work that's going on simultaneously. And we are working on the housing instability data set identification, as you can see, and we are still in the second quarter of 2020. Next slide, please. And I will let Sarah address this, or Linda. I believe it's Sarah.
Hi, yeah, this is Sarah, everyone. We're not doing the full review of gravity process today, but we did include all of the slides of the overview that we presented at the last call. It's at the end of these slides, and so you can feel free to review those slides on your own after the call. Again, this presentation is recorded and posted to the Confluence, but just as a level setting, again, this is the interaction of the two areas of work, the social determinant terminology work, which you are on the call to hear about today, and the output being eventually coded value sets and how that intersects with the technical work of developing the fire standards. So just to talk about those representation of those two bodies of work, just to kind of orient us, and every single presentation now, the overview of gravity process can be found in the last slides for review after the call. Thank you.
Thanks, Sarah. And hopefully this is helpful. We've had several questions in the past about how all of the pieces fit together, and that's a great snapshot for everyone to refer to if they have any questions. And let me check chat and make sure that we don't have anything to address at this point. Okay, next slide, please. I will hand it off to Linda now. Oh, did someone have a question?
No, that was just me. I was gonna.
Oh, okay. Okay, sorry, Linda.
No problem.
I got all excited there for a second. Okay, I'll hand it off to you now. Thanks.
Okay. Well, we wanted to provide you with an update on where we stand with the submissions of all of the concepts that we identified in food insecurity as being needed to represent that domain. So we've been actively busy, and I believe in earlier presentations we discussed, that we've done some of the submissions. So I just wanted to give you an update because we're showing some progress. First of all, for LOINC, the latest version of LOINC was released on the 17th of June, and this includes 3 of our USDA screeners that were part of the Master for Food Insecurity. They're the 18, 10, and 6-question version of those screeners. There are additional screeners from the master list that we are preparing to submit for consideration in the next LOINC release, which will be in December. We've also submitted
Linda?
all of our, sorry, yes?
Excuse me, acceptance of 3 screeners submitted by Gravity. Is this typical for participants who want to influence nomenclature? Are these the most important screeners that any of us would have pointed to? Could you just comment on the significance of 3 being accepted?
Well, we submitted these first 3 primarily because they're the main USDA screeners, which is essentially the gold standard for the validation of all the subsequent screeners that have been created, and also due to the time frame with which we needed to submit to LOINC for the June release. These are the ones, in talking with the people from Regent Street, that we felt the most comfortable that we could submit and actually get included in the June release. So we went with those first while we worked on the rest that are coming up on the list. So we'll be continuing to work with the rest of the screeners. Some are proprietary, so we have to go out and get permission from the owners. Others we need to work through all of the materials that we need to submit along with the submission form to Regent Street for their inclusion in LOINC, which is why we wanted the additional time to work on those for December.
Thank you.
Okay. SNOMED CT, we submitted all of the food insecurity diagnoses. We actually had 3 that we needed to add for the mild, moderate, and severe food insecurity. And as you remember, for those of you who participated in food insecurity, we had a lot of interventions because that was one of the underrepresented areas in SNOMED based on the work that we did over last summer and fall. So all of those have been submitted for consideration in their upcoming release, which is in September. We know that there are people actively reviewing these concepts in SNOMED because I get email notifications if there are questions or things that need clarification. So they're working through that list now. We will keep people updated as we learn more information about their status. In ICD-10, we had those same 3 severity level diagnosis codes that we wanted to include in ICD-10. Those have been submitted for review. The next meeting for review of submitted ICD-10 concepts is the September ICD-10 coordination and maintenance meeting. So we'll keep people posted after that call to see what that status is for those diagnosis codes. So periodically, we'll keep you informed of how we're doing these statuses. And I believe on Confluence, we've actually posted those submission files so anybody can go in and see what we've actually submitted to these different terminology systems for their own review. Any other questions? Okay, then we will move on. I believe I'm up next for this one, yes. So again, this is just our update on the data concepts. Now this is for housing instability and homelessness. This is the representation of the logos of all of the organizations who have submitted to us. And here is the current status. So we received a total of 14 submissions. We've reviewed 13. One is still being in the process of being worked on. And you can see the dispositions here. We've returned 10 of those submissions. I have a couple more. Once we had calls with 2 submitters to clarify and ask them questions about some of their terms. We've had those calls. We will finish their review. Those are the items that are marked down here as hold. And as soon as we do that, we should be able to return several more of these submissions to complete that process. And I believe now I'm going to turn it over to Sarah, and she's going to talk about end-to-end review for diagnoses and goals this week.
Linda, thank you so much for reporting out about all that work. Again, I was super excited to see the USDA tools come into Loink on Monday. So we're going to now review basically the final presentation to the community for diagnoses and goals for housing instability and homelessness. Last week we presented on screening. We are eagerly awaiting any comments on that end-to-end review for the screening concepts. And this section is the diagnoses and goals section. So it's such a small presentation. The master list will be sufficient, and Linda will that will be available on the Confluence, and so you can download that and review the diagnoses and goals there. And we'll review the process for end-to-end review at the end of the presentation. Next slide, please. I did this for for our friends who loved the graphic before. So this was the ICD-10 diagnoses word cloud in progress. Next slide, please. So this is where we're ending up after a lot of labor. So I'm going to walk everybody through where we're ending up and why. So there's an existing code in ICD-10, which is for homelessness, C59.0. That was already there. That's the base. What we're proposing is to ask SNOMED to change the SNOMED code from homeless to homelessness, because that corresponds to how we ethically address individuals and the concerns that they are dealing with in their lives. And then what we are going, if you remember the last time we presented concepts that mixed chronic homelessness and sheltered homelessness and unsheltered homelessness. So there was a chronic sheltered and chronic unsheltered. Part of my review of community-based organizations, of which I've done a fair bit, again, because everybody was fairly busy on the ground taking care of individuals with COVID, so we had to kind of meet them where they were. Created an ask for a refined and more simple presentation based on what we absolutely need. So This has been brought to the National Coalition for Healthcare for the Homeless. It's been brought to all kinds of individuals who work on the ground. The recommendation is to parse homelessness into two children. One would be sheltered homelessness and one would be unsheltered homelessness. The benefit of doing this is that it really addresses the needs from the healthcare perspective. If we think about discharge planning, that was what I've been talking to folks a lot about. The difference between planning for discharge planning with unsheltered versus sheltered homelessness are quite significant. So as we did with food insecurity, trying to represent granulations of these concepts that actually allow us to direct services and identify risk. So this is the final presentation. We would love your thoughts on this one. Again, it's a little bit simpler than we had some in previous presentations, but this is part of what we do at Gravity, is suggest things and then glean and winnow them down to what is absolutely necessary. And then these ICD-10 concepts that we'd be asking for would then be mirrored in SNOMED concepts that would match. You see the two definitions for homelessness below the 2012 and 2014 definition. I do appreciate the 2014 definition because it gives clinicians and coders fairly tangible information to act upon. This information has not been rendered through the computable logic requirements of FHIR, and so there's some fair bit of work to do here. But the next submission for ICD-10 is not until the winter of next year, so we have some time to work on the definition together. Next slide, please. And then for housing instability, we don't quite know where the route would be for this concept, but the suggestion of the community at large is to create a specific code, which is the bucket for known housing concepts which are associated with risk, which are not homelessness. So these are concepts such as at risk for eviction, behind on rent, history of multiple moves, doubled up, and housing cost strain. These are the concepts we identify in the literature and have known associated healthcare risks, and we want to make sure we're representing them discreetly. So the ICD-10 CM code would be housing instability related to limited economic resources. And then the SNOMED concepts, sorry, there would be a matching concept to the housing instability related to limited economic resources. And then there would also be these sub-concepts, because SNOMED allows you to get a little bit more granular than ICD-10 CM and ICD-11 even. So we would be asking for these specific concepts in SNOMED in addition to the general parent. And then those would be able to be monitored through problem lists and through referrals. We also are going to be asking for a history of homelessness code, of which there's none, and we do know that's associated with risk in the literature as well.
Sarah?
Yeah, hi.
Hi. Hi, everybody. This is Lucy. Is there a temporal dimension to this problem list, like in the last year or in the last 6 months or the last 10 years? In other words, people's economic situations can move up and down like a sine curve. And I'm wondering whether we've thought about the temporal duration or period of clinical interest or intervention interest. If you're asking somebody during a clinic visit any of these problems, are you going to say ever or within some time frame?
So history concepts usually have a time frame. Present concepts are now, and then there is of course best practice for auditing problem lists. Usually it's at least yearly, but this comes down to practice. I think it's a little bit challenging. So the SNOMED codes exist, but I didn't note this in my presentation, but there are also key components in history and in social history. For instance, in my clinical practice, we have to audit the problem list every single time we see the patient and resolve or make inactive anything that's not relevant. So we don't necessarily dictate the process, but certainly it would be best practice to audit and assess anything on a problem list within a reasonable, like like period of time, and then anything that's in the history section, the social history or family history section, you would develop your own protocols for that as well.
Well, what if patients move around? What if I don't want to take up a whole lot of time with this, but I think the idea of standardized coding is that whatever gets coded will follow the patient essentially for life as they change providers or change their situations. And so to say that this is updated every time your clinic might see a patient, I'm not sure how that works. If the patient leaves the state and goes somewhere else and somebody discovers that they're behind on rent, and then they have to say, well, when was this? Or how often? Or are you still? Or that's what I'm grappling with.
Yeah, I don't want to get too far into the
Okay.
well, only because so ideally, in community and community care of individuals, we'd be communicating on a regular basis, right? And we'd be communicating bidirectionally. So should something change, we would hope that our community-based organizations or our housing partners would help us understand that as well, or community care managers or social workers. And then should a patient transfer, the onus would be on the person who's receiving the patient to ask similar questions, especially within the data standard approach, to make sure that the list represents the individual. And then we've talked about this before. I don't want to get, again, too far into it, but part of patient-centeredness is actually co-shaping the list with the patient. So making sure that the things on the list represent the concerns of the patient, identifies them as well. And that's something that in best practice is dynamic and iterative and collaborative over time. And I would love to talk more about it. Is that helpful?
Okay. Okay. It sounds really optimistic to me, a very provider-centric view of how people are dealt with rather than the lives of the people actually dealt with. But that will get us into a huge philosophical quandary. So let's move on.
Or maybe we can use that. I think we can. I don't want to shortcut any conversation. And perhaps maybe this is the end of the diagnoses section. If you go to the next slide, we start goals next, I believe. So so let's look into some of the questions and see see what we have.
Sarah, this is Lynette. There was an initial question about whether what kind of body ICD-10 is governed by, whether it's U.S. or international. Do you mind answering that first, and then we can look at the chat?
ICD-10-CM is the U.S. version of ICD-10, and these concepts we built into U.S. use alone. We do the ICD-10-CM committee of the CDC, which is the NCHS, CDC, national NCHS. I'm trying to remember the acronym there right now, but they do communicate. Donna Pickett does communicate with international ICD, which is directed by the World Health Organization, but our application is for U.S. use.
Thank you.
And then, are there patient surveys linked especially to these ICDs? For instance, I don't know, this is an EPIC as part of it. So there is a lot of work being done in medical social care integration for mapping screening outcomes to ICD-10 diagnoses. And certainly when we suggest ICD-10 concepts, we have the screening tools that we've been building into LOINC in mind. So one could map the outcomes to the identified, one could map the outcomes of screening questions to diagnoses. We did that with food insecurity as well. Would the LOINC associated concept map to the questionnaire describe the temporal period? So that's a little bit difficult because the USDA tool allows both a 12-month and 2-week look back. So in working with the NQF approaches to food insecurity through the quality metric, it is adaptable. So one of the ways to ask the USDA tools is since the last time we asked you. Again, so Christine Joseph mentioned that in her comment as well. So the tools are able to be adapted in some range to marry the way you're asking the questions in your clinical practice. Behind on rent. Should we have behind on mortgage as well? That is a good idea. Maybe we could submit that through our end-to-end review. And then, okay, concerned. Okay, so let's have this conversation more openly, because now there's multiple, it's not just me and Lucy talking, which I always worry about talking too much. Could individuals who want to discuss the temporal nature of the data, please unmute themselves, and then, and Lucy, if you want to go further, because there's a bunch of people who are agreeing with you, and maybe we can collectively think of a strategy and recommendation.
Time for other people to speak up. Thank you.
So what is the recommendation for the risk of the data getting old, right? So the, because it's certainly the data, I certainly admit that I described ideal practice, and that's not, so do we have ideas in the group to suggest, as we are recommending these coding concepts, to support best practice with making sure the data is relevant for the patient at the time of encounter? Anyone?
Hi, this is Michelle, and I work in a community-based care coordination program. So I certainly agree that if you were going to put something temporal in a problem list in the clinic, that definitely gets problematic. It's hard to maintain. But when you use ICD 10 codes for submitting to managed care organizations for eligibility, for example, I would use an example of a program that we have here in Washington State that is for supportive housing, and that eligibility requires 12 plus months of homelessness. And currently there's no ICD-10 code that would reflect that. So some of that billing is a little more complicated because there's no data standardized.
Michelle?
Yeah.
Your connection's really fuzzy, and people really want to hear you, and we're having a little bit of a hard time.
Sorry, I've been having a difficulty all day with my connection. Anyway, so what I was just saying is I could understand how the history would be a problem in a clinical setting, but how it would be useful in care coordination setting to have that the temporal data and standardized data. We do use that for eligibility and billing.
This is Matt Bishop from Open City Labs. The Health Home program is a care management program, and they are billed. In the move to value-based care, there's a lot of billing per member per month. So like reporting requirements associated with kind of on a monthly basis. So I would imagine that kind of with that could be a starting point. I'm not a clinician, so I'm not sure if clinicians would want any more granularity or time specificity than that, but I think it makes sense from an administrative perspective.
Any other thoughts about, and certainly the statement that these can be on the problem list doesn't mean that they necessarily need to be. And I do feel like one of the things that Gravity can do is really represent the risk. Again, we try to do this within other committees, is represent the risk of creating this data and the sensitivities that need to be adhered to in the utilization of the concepts. Any other thoughts? Because I really want to honor.
Sarah?
Yeah?
This is Donna Rugg. My comment on the problem list, in my experience, is that typically, at least on an inpatient, it's it's not always updated. The providers are fairly inefficient at sometimes updating it. So to me, if it's an ICD-10 code that the coding staff would be assigning, then they would generally not always use a problem list for a documentation source, but more the clinical documentation by the provider or the other clinicians within the time frame of that visit or admission, because problem lists are not always updated timely.
Yes, and then this comes into some systems use problem-based assessment, so you have to choose the problem list. So it becomes, I think, any other comments? Because I want to make sure we want to build the concepts to be able to address risk, but we also have an opportunity to suggest the risks of doing so. And again, this is something that we consider a lot in the construction of our data principles, but is anyone making argument for these concepts to not be within SNOMED because of the risk of them possibly ending up in a problem list, or just to make sure that I understand the way to go forward? Because SNOMED offers, it's beyond the problem list, of course. It's social history, surgical history, family history. Problem lists are just a facet of that.
Sarah, it's Mark. Wasn't the original question whether there was a temporal frame on the screening question? And I don't know, seems like that's a distance to travel to a question about a problem list.
So maybe Lucy, did I misunderstand your question?
No, I was asking about the temporal dimension with respect to the items in the problem list.
Yeah.
Trying to imagine a new patient being asked all these questions, and then that patient leaves town, leaves the state, and then depending on the answers to the questions that another provider might see, assuming we have all the interoperability that all of us know doesn't really exist, but might, then the provider thinks that somebody has a housing cost strain, and they don't. They left the state to better themselves and did in fact do that, and now being asked about that is annoying and time consuming, and then they have to explain how come this is no longer relevant. And so yes, it did apply to the problem list.
This is Terry Cullen. This is one of the holy grails in clinical recording, right? And if it's on the problem list, obviously it depends on your facility and the way people manage their problem list. But you are right. Most people would assume if it's on the problem list, it's pertinent to the time of the visit when you see the patient, because it's moved from a purpose of visit to a problem list. However, most problems lists these days have active, inactive options. So I think this is a real issue. I don't think we're going to solve this because I think this is a process issue, the way POV and problem lists are used. And so perhaps there's some guidance that could be promulgated around what is appropriate use of a problem list versus appropriate use of a purpose of visit.
Sarah, this is Lisa Nelson. I wanted to share some experience from being in MaxMD, being an implementer during Connectathon on some of the early work to assure people that there's a difference between the clinical observations that are being recorded and the fire structures that are being used to gather and collect clinical observations that are made, separate from condition resources that would be added to record problem list items. And I just think that, you may have to take this at a different level to the community to get into understanding the nature of the data accumulation. But there's definitely structures defined in the IG that hold these clinical observations separate from and distinct from, and saying that there's a diagnosis on the person's problem list. So I know the slide says diagnoses, but to me what you're really talking about first and foremost is the recording of clinical observations that may be made during that interaction with the patient during the history and physical, when the clinician is interacting, talking, being with the patient, and determining if these risks are present and in what shape or form.
So I always appreciate this group so very much. So what I realize I've been speaking from, and forgive me as I presenting the things that we've suggested to say, is that we can't ever, of course, forget the effects of saying them, right? So I do feel like this is a very complicated conversation, but it's one that needs to be had. So it's what the work of gravity can't just be creating the things that we want to say. It also needs to be taking some responsibility for how they're said, right? And I always respect Lucy for calling light to that from the patient perspective. And I'm wondering if, so Lucy, I'm wondering if we can have this conversation within the committee, because I think it's too important to not discuss, and take it forward from there. She might be on mute, but the good thing is that we do have groups of people who remind me and remind everyone very well that it's not just about creating the things we say, it's about putting them into use and monitoring how they're used, and then coming back to make sure that what we hypothesized was correct in the first place, and making sure it's alive and iterative and keeps the perspective of the patient at the center. So does moving it to the some of this conversation to the TAC make sense, Lucy?
That's fine. I would just say that maybe there are at least two strategies here. One is what you have up on the slide, and that's one output from this entire discussion. And another is that everything on the slide can have an asterisk where we try to capture the discussion about, if you're going to talk about a problem list, be sure to have a time frame in mind, or use the time frame in your EHR, or if you don't like that, make some new observations that may or may not turn out to be billable. You know, some conversation, because a lot of this, I don't know how familiar it's going to be to people who ultimately see our product, but the conversation has revealed that this is complicated, and Lisa has reminded us that there is an inflexible hierarchy once we get to coding. And so some narrative strategy somewhere along the line might be helpful without having to necessarily change anything on the slide.
I love that idea. So maybe that we can reflect on how to do that in between now and when we come back. And I really appreciate that we're having these conversations this time around. I think it's kind of an evidence of our growing as a community, that we're able to have these kinds of conversations when we put codes up for conversation, because these are more sophisticated and frankly, I'm not going to say more important, but very important, comparing with the conversations we were able to have around food security. So lovely. Okay, so I think I understand the action items there. And thanks again, Lucy, because you're just a gem. So next slide, please. Oh. Wow. Piano music in the background. I love that.
Nothing like a little Bach to facilitate the conversation.
I'm a fan of the cello suites myself, and that was lovely. Okay, so again, I so appreciate this group. So this is where we've come to with our goals for housing instability and homelessness. You'll see that's a little different. Again, it was the suggestions were born out of the conversations with folks on the ground, and specifically regarding some patient perspectives. So Suggestion for goals would be housing security as a general goal, access housing resources. That's a general goal as well, because it kind of meets all the possible subdomains of housing security, which is like homelessness, housing instability, et cetera, or inadequate housing. We were asked to add access permanent housing. So if someone was living in temporary shelter, the idea would be to access permanent housing because of how important it is for well-being. And then a last goal of accessing shelter. So if someone was unsheltered, the primary goal would just be access shelter. So you'll see that we've added two from the housing security and access housing resources base that we presented last time. And then just to represent the iterative work of it all, in consideration after when the SMEs and I and some community-based organizations have been talking about is still there's this desire to represent the labor that go alongside with helping folks maintain housing. So this idea of a goal could be maintain or access the supportive services that are required to maintain housing, such as mental behavioral health services or disease management. So because the work of housing doesn't stop when a patient is placed in a program or a person is placed in a program, one of the things we're trying to figure out is how to represent that goal, which goes alongside the housing specific goal because it's required for maintaining the housing in question. Any thoughts here? Does this seem like a good step from where we were before? Yeah. Kate says yes. Yeah. All right. So again, so these are the goals. These four are the ones that will start their end-to-end review when you download it from the master. And then the diagnoses as previously presented. So the housing instability concepts, the homelessness concepts, and those new concepts in SNOMED. Oh, yes. And then this answers my question, says Denise. That's lovely. Oh, okay. Yes, it did answer your question. That's fantastic. All right. So next slide, please. This is just a reminder of how to submit end-to-end review comments. So download the housing instability list. It's on the Confluence. If you need help finding it, we're always here to help. So many kinds of housing. Yes, there are so many. Email us any comments you have. Again, we're specifically looking for things that we are on the master list and you feel like need to be changed or might need to be removed because we don't want to do anything excessive. We want to do just what we need to say. For things that are not on the master list and should be, you can either submit the data element type. You want to submit the data element type in your comment. Again, we're looking for screening, diagnoses, goals, and interventions. Describe it, and then if you're suggesting a screening element, please attach the tool so that we can reference it when it's adjudicated. And then comments regarding diagnoses and goals are due on the 23rd of July, which is right after the screening, which are due the 2 weeks prior. Next slide, please.
Sarah?
Hi, yeah.
Hi, could you go back to that slide with the goals on it with those four icons? This is a really off-the-wall question, but someone comments in the chat, there are so many kinds of housing. Would it be completely crazy for there to be only one goal, which is housing acceptable to the patient?
That is absolutely not crazy. No.
Maybe the patient doesn't, I don't know. We know that there are people on the street who are adamant that they want to stay there.
Exactly.
And we as public health NICs or clinicians or whatever we consider ourselves to be, find that relatively incomprehensible, but may honor it in response to autonomy being a very high value. So all the way from that to housing that doesn't work. It's too small. There are rats. There, we could spend the next 30 minutes imagining all different sorts of housing situations, but the one that matters is what the patient wants. Otherwise, and that's relevant because if you're going to prescribe WIC coupons to a mother who doesn't want to be housed, then she doesn't have a fridge, and you have to know that. So I'm struggling with what's really pertinent from a clinical point of view, not necessarily from a social welfare point of view.
I love that idea. I think what we would want to do is represent all of the goals a person might have. And what you've just stated is we're missing the one where it just says, I'm fine.
Yeah.
Right. So I think what I hear, and we actually did not do that for food insecurity either. I think the access shelter and access permanent housing granularity were driven by patient voices, right? So I would be loath because for some that is their goal, right?
Yes.
But I think it's important to state what you just said, which is for some it's I'm fine, right? I just want to stay the way I am. So yeah. What we'll try to do is capture your wisdom and put that in as an end-to-end review comment as something that's missing. Does that seem?
Thank you.
Okay.
Okay, great.
Yeah. All right. Okay. Gee, I so appreciate you, Lucy. Okay. Moving on. So I think, not quite sure where some resources would fall between housing security and housing resources. Oh, that can be a little bit confusing. So for folks who, there was a schematic we presented earlier where housing security includes all three concepts: inadequate housing, homelessness, and housing instability. And for some individuals, just identifying that as their meta goal is the way some individuals might want to say is the intention of care planning, which is where these goals will start to materialize in practice. And then for some individuals, it's about connecting to resources. And this correlates to some of the conversations we've been having with folks in review of submissions. Like, you want to go from not having part of the plan might be to just say, I'm going to call 211, or I'm going to call this person. I'm going to get connected with a social worker. And that's where the access housing resources comes in, where it's actually the activity of accessing the services, which is the goal for the patient or the person in between this visit and the next one. So each of those concepts kind of deals with a different goal. The housing security is kind of a meta concept, and the rest have actions. And then Jason says, maybe in that case, goal is maintain housing. Or, well, it's challenging because in that instance, you're not housed. So if you're content, if you're content to live on the street or live in a tent or live wherever you're living, you would not say that you were housed. I think, does that seem correct for some of the folks on the call? It seems so. Okay. Thank you.
Sarah, this is Lisa, not to sound like a broken record, but again, the difference between the clinical observation and the notion of a problem demonstrates the difference here. So the observation is the person is homeless, but there isn't a problem on their problem list that identifies homelessness as a problem, because there is not an issue that they want to work on there. So the distinction between things that are observed versus things that are judged to be problems is a distinction, and the big difference between data that is semantically represented as an observation versus semantically represented as a condition.
Thank you, Lisa. And then Gabe and Jason are helping me understand a little bit better about what Jason's comment was supposed to be intended. I think I might have misunderstood it. So I wonder, so Jason, do you want to unmute yourself so we can hear what you have to say? And then we might need to move along to get everything in the presentation today. We're ending. Jason?
Sure. Yeah. I mean, I think Gabe kind of caught it in, and perhaps the idea is that, as was described earlier, someone is satisfied with their current state, then maybe maintenance of that is the focus. And so there is a general kind of pursuit of maintaining their living situation or their state of residence, which could mean I'm living with my brother, I am van lifer living in my van, or whatever. Those technically, according to HUD, could be considered homeless, and yet maybe desirable states that someone would want to persist, and that could be the goal. Oh, something like that.
Yeah. Okay. So I think maybe we can wordsmith. I know we captured Lucy's idea, and maybe we can wordsmith that, and then I'll try to reach out back to all of you in email, and then collectively y'all in the call next week, in 2 weeks when we come back with what we've crafted to see if it meets everyone's needs. Does that sound good? Okay. Any other questions before we move on? We have to quickly present on inadequate housing. We've had a lovely conversation, but we are going to try to end at 5 today, which is, I realize, a little bit early. Okay, so I'm going to go through to the next slide. I think Linda, you have inadequate housing data updates.
Yes, thanks, Sarah. And this one will be pretty quick. It's going to be similar to what we've been showing all along on housing instability and homelessness. We took the first set of concepts, and these are primarily ones that were parked. They were submitted with the housing instability and homelessness, but adjudicated to be not in that domain, but more appropriate to inadequate housing. So that actually created an initial list of concepts to adjudicate for this domain. So as you can see here, we had 3 organizations who included concepts that we felt were appropriate to inadequate housing. So you can see the total statistics here above of the counts, and you can see that this first row for the additions, this represents our first master list for inadequate housing, which we will publish similar to the housing instability one. It will be published in a few days from now when we send out the notice that the slides, the recording, and the master list is available. So you can see this is our process. We'll be starting this, kicking this off, and we'll be adding to this as we get additional submissions from you or from work with our SMEs for inadequate housing. All right, so I think, Sarah, I can turn it back over to you with, oh, this is just, I think we'll put this slide at the end just for as a reminder of what the dispositions mean for those people who get their submissions back.
All right. So that's the inadequate housing in progress. And again, so just to catch people up, we started with housing instability and homelessness within the grand bucket of housing security. And then last time we met, we kicked off work focusing on inadequate housing. So like Linda was saying, a lot of the submissions for screening concepts and even original concepts for diagnoses contain some of the information you'll see in front of you right now. So next slide, please. So I just wanted to basically parse out a general gist of what the inadequate housing data set kind of looks like right now. So the core of it is often the Naruzaman tool, which came out of a medical legal partnership in Norwalk, Connecticut. I will talk about that in a second. Inadequate housing is also the CART of the American Housing Survey and the Housing Insecurity Supplement in Development. Children's Health Watch Tools has a lot of concepts regarding housing quality. There's the existing ICD-10 code inadequate housing Z59.1, an existing SNOMED tool, a concept that correlates with that. And then the what we will work on in development is the subdomains that correlate with inadequate housing, like lack of electricity, lack of stove, mold in the home. So we can work on the SNOMED subdomains as we go forward. There's nothing in goals yet. And then for interventions, we just have everything we brought over from all of our previous work. So anything that's general as to social determinants, we just fold in from one data set to the next. Last time we presented the HUD definition, which is a definition for the house, which we got, I think it was Art or somebody who was talking about the complexities with that at that time. So a person definition in process would be the experience of being in that house. So it's not going to be a house definition, it's going to be a person definition, and we'll have to refine that over time. Next slide, please. Again, I just wanted to highlight the Nehruziman tool. You'll see that it's the core of many of the screeners, the comprehensive screeners, and it's definitely the core of the Accountable Health Communities tool. There's a first question which often gets left off, which is your health or your family's health affected by conditions at home? Yes, no. And then usually that first question is left off, and then there's just a general, what are the conditions, any of the following conditions are true for your home? So this includes bug infestation, mold, lead paint and pipes, inadequate heat, a non-functioning oven and stove, and smoke detectors and water leaks. And I think, the next slide.
Sarah?
Oh, sorry, this slide was supposed to be skipped. Yeah? You can go back.
It was supposed to be skipped. Could there be a bullet added about noise? One of the odd things about sequestering at home during COVID has been people's realization of how noise has really bothered them, and suddenly it doesn't now. And so
that's a really important observation, Lucy. I think that is really important. So I think it's easy to we could figure out how to include that in the definition. Yes.
Okay. Thank you.
And then, so Lisa's brought up domestic abuse and violence, and we have talked at great length in the past about the intersection of intimate partner violence and homelessness, especially as it correlates to defining homelessness for HUD and HMIS. We so far have leaned towards keeping IPV in its own diagnostic tree within ICD-10 and within its own screening approaches. We had a really robust conversation about it, I think it was like a month ago, but we're always open to figuring it out and re-examining issues. So maybe I'm just going to finish this last slide, and maybe Lisa, we have time to just hear you out a little bit. So again, when we look at submissions, we're looking for screening tools, assessments for diagnosis, or as Lisa would point to, observations. Goals of care and interventions are our big gaps here. Again, you heard us have a goals of care conversation for interventions. Program names and the definitions of those programs are helpful. Provider or practitioner roles, what I always suggest is the community healthcare navigator. The reason why these provider and practitioner roles are important is that we can refer to them or consult with them. And then any applicable intervention or activity or service. And so each of these things, the program names and definitions and providers and like professions and practitioners and activities and services then get plugged into our intervention framework and get built out into the intervention concepts in our master. You'll see that as you look at the housing master, it contains these core programs with definitions and professions, and then a ton of different activities that wrap around them. Just a brief, very small note, we found in Hawaii that many of the descriptions of inadequate housing do not apply to life in the tropics. Well, we should make sure that we include concept of inadequate housing that apply to life in the tropics. And then we have another comment from Laura Langford, hi, about number of animals, or there are concepts of the status of the home, which can be encapsulated in adequate housing as well. That might be something like that we can consider. Maybe we can talk about that. And then if patient asks about animals, yes, it's true that we would. Yes, you get worried about people taking away your pets. Lucy has a comment there. So Emily, I'm wondering before we go, since we're about out of time. It's 5. I'm just going to try to hold this for a few seconds. Would you talk to me offline about how we could possibly improve the inadequate housing definition to encapsulate concerns in the tropics? That'd be great. You can just, yay, thank you. Whew. Next slide, please. I think that's it. I'm just going to go forward to homework before we close. Again, all of the materials as presented are recorded. The slides are there, and they're on the Gravity Confluence page. I'm going to tell everybody we are working on our presentation of information, so hope we're making a community-facing web page that should be easier to navigate and find deliverables, and so we're looking forward to that. Please review the master and screening, the master list, and then the screening summary. The screening components were so long, we made that abbreviated summary for you to review, which just kind of pares it down. The master list is definitely sufficient for the diagnoses and goals. Send comments. Please send comments. And then inadequate housing, submit new concepts, either via the online tool, via the Excel spreadsheet you can download from the Confluence, or directly on email. And again, there's always a link to the homework at the end of the call. I'm loving the conversation regarding bugs in the tropics. It's I love it. Next slide, please. I think that's, yeah. So also sign up to join the 2020 September Connect-a-thon. And then as always, thank you for coming to the call. You give me and the collective a lot to think about, and we're so grateful. Oh, sorry, back one slide. And then if you are not a member, please join as a committed member of the interested party so we can have you on our emails. We'll meet again in 2 weeks' time. If anything was unclear, please give me an email or send us an email, and we'll come back to you with the action items as identified. So the TAC is going to think about some implementation concerns regarding problem misutilization and the risks thereof and temporality. We have a goal suggestion, which is the I'm fine goal. And then we do have some considerations regarding inadequate housing, including animals and tropical considerations and noise. I think I summarized it. Thank you all. Any final comments or questions before we call the call? I love that Missouri is echoing. Yes. Thank you all. Any final
Great
comments?
work. Great work, Sarah. Thank you.
Thank you. You all have a lovely evening.
Bye.
Bye.